if there is any in the meantime, when there will be Dr. SAVLEEN Kaur, she will be presenting IOL power calculation, which is extremely important and not known to many of the because how to calculate IOL power, particularly for children, it is very very difficult situation and challenging job. So Dr. Savleen Kaur will be presenting IOL power calculation in pediatric cataract.
Thank you so much, sir, for the invitation and putting up this wonderful IC and getting selected for the third year in a row. I will be talking about IL power calculation and I'll try to simplify it, although it's a topic that requires a lot of debate and a lot of discussion, I think. Why are we talking about intraocular lens implantation in children? Why is it different from adults? Is because we get a lot of refractive surprises in children. These are mainly early refractive surprises which are attributed to inaccuracy of intraocular lens power calculation, and you also get late surprises because of the myopic shift that the developing eye is undergoing. So I'm going to talk about four aspects in my presentation. To begin with, I would talk about axial length and keratometry measurement. For an axial length measurement in adults, you have the optical methods to do that, and they are the gold standard. But office measurement of axial length in children can be very difficult because of their inability to fixate. You can do the axial length measurement under anesthesia, but these are also coupled with the uncooperativeness and lack of precise fixation under anesthesia. The errors in measurement of axial length contribute a lot to the intraocular lens, 2.5 diopter per 1 mm as we are conventionally taught, and this error jumps to around 3.75 diopter for every 1 mm error in axial lens that we encounter. It can be measured with applanation and immersion. The applanation is the most convenient one that we have. They are very accurate if you do it with a trained biometrist. They do cause a corneal compression because you are indenting the cornea and you get average 0.27 mm shorter readings than the standard immersion technique. In office, if you try to do the excellent, that is how you see you have the uncooperative child who is trying to uproll the eye. You have Bell's phenomena, and you hold the child and you do it, and the chances of getting an inaccurate excellent are much higher. You can do it under anesthesia using the same contact machine. It's not that I have put three different pictures. What I want to tell here is that we have to take multiple readings of the same child even when we are doing excellent measurements under anesthesia. Be careful not to indent the cornea much because corneal compression is also more likely because of their low scleral rigidity. And you have to have an instrument that is calibrated. You can use any one that you have, but you should have an oscilloscope screen that tells you that echo spikes coming from the lens. There are many excellent scans available, but the multiple readings without indentation can be safely used as an excellent value in children. Inaccuracy of keratometry measurement can cause errors up to 0.8 to 1.3 diopters. So in cooperative children who are fixating, you can use the optical method as well. But conventional ultrasound technique you cannot use in children. So the handheld keratometer is an option which you can use in office. I like to do it when the child is either feeding or sleeping in the mother's lap. You get accurate multiple readings. You can get accurately in the office also, but under anesthesia again you have a problem of lack of fixation, and you need to take at least 2 to 3 keratometry readings and try to take readings who do not have a large standard deviation. They should be within 1 diopter of each other. This measurement is ideally should be taken without a speculum, and you should avoid corneal dryness and keep using BSS to maintain a smooth corneal surface. So once you have the excellence and the keratometry, you have the question that which formula do you use to put in. So there are a lot of formulas, regression and theoretical, and now we have the 5th generation available. We try to do a review on what is the best intraocular lens power calculation out of the available literature. And we saw that there are a lot of formulas which are advocated for small eyes were being used in children, but actually children are not small adult eyes. They might be normal for their age, and you might not be using the correct formula if you're using a formula for smaller eye. So currently there is no consensus, but we are following what the IATS has taught us, that Holiday 2 and SRKT are the least inaccurate formulas. So these are the formulas that we use in children. So you have the exit length measurements and you have the keratometry. This is Dr. Jasprit feeding in the data in the machine that we have, and then you decide on the SRKT or the formula that you want to use, and you try to get the intraocular lens power. You have obtained an emmetropic IL power, and now you want to decide what is the target refraction that you want to keep with the IL power with you. So how do you decide what is the target refraction? You have to undercorrect to counteract the myopia later, but you do not want to have amblyopia in childhood, so you want a balance of the least refractive error early postoperative period, and you also want a stable refractive error when the child grows up. So you, based on the normal growth patterns, you want to avoid a high myopia, so that's why you target a moderate hyperopia in the immediate postoperative period, low enough to be corrected either by a contact lens or by glasses. How much to undercorrect? Now, Dahan taught us conventionally for children less than 2 years to undercorrect by 20% or use exit length and then calculate the power. This gives you a hyperopic refractive surprise from 6 to 8 diopters. It is a little higher for the initial postoperative period, especially if you have a unilateral cataract. So people started advocating a little low to moderate hyperopia, the rule of 7 as proposed by Enyadi, or Crouch et al. Proposed what is mild hyperopia up to 4 years. After that, emmetropization is usually achieved, and that is practically what we are following now. So we did publish a lot of literature on intraocular lens implantation even in infants, and we chose +4 in infants younger than 6 months, and that is what mostly we follow. The infant aphakia treatment study, that is the largest evidence available. It says that we have to undercorrect by 8 diopter for infants 4 to 6 weeks of age. So you have to consider a lot of factors when you choose what method you want to do. What is the age of the child when you're operating is the most important one. Unilateral cataracts, you might not want to have a very high hyperopia, and if you have a dense amblyopia and then you give them high hyperopia, itself defeats the point. Expected compliance with contact lenses can be a deciding factor, and if you have a parental myopia, the chances are the child is going to be myopic much more later. So this myopic shift is basically as compared to a normal child. When the child is progressing, there's an increase in axial length and the lens is flattening and the flattening of cornea is compensating for it. But in cataract, what happens is because you have this increase in axial length, which is not compensated by the lens flattening and the cornea flattening because of the surgery also that you might do. So there is a further increase in axial length and usually you get a myopic shift. In Indian eyes, we have seen that the myopic shift goes up to 8 diopters when you operate on a child less than 6 months of age. Again, a publication by our group. So to summarize, the major challenge after a well-done pediatric cataract surgery is the post-operative refractive error, and this depends largely on the power of IOL and the post-operative target refraction. There are a lot of inherent difficulties in the pediatric eye, which makes the IL power calculation difficult. So we have to obtain an accurate IL power by taking some precautions while we are doing office measurements or measurements under anesthesia in children, and then do an age appropriate calculation for these powers. I've learned everything from Dr. Jasprit, so thank you, sir, for everything that you've taught me, and thank you, Dr. Jagatram, for having me here. Thank you.
Thank you, Dr. Savleen, for covering this subject very well. I think this is in pediatric cataract surgery, this is much more difficult to decide that which IOL power you are using. Any question, comment from Dr. Jasprit?
Yeah, I mean, no doubt. I mean, it's that's why it's so unpredictable in children because in especially younger children who cannot go through an IOL master, they are not fixating, so you do not know where the scan is going. So just to have a brief summary, what are we following for the target refraction according to the age? In yeah.
So the slide that I showed, what we are targeting less than 6 months is we target around +4, 6 months to 1 year is +3, 1 year to 2 years would be around +2, 2.5, 2 to 4 years, 2 to 3 years would be +1.5 to around 2, 3 to 4 would be +1. After 4, we can make the child emmetropic, specifically if it's a bilateral cataract.
Yeah, so probably I think by 4 years we make the child after that emmetropic. So it all depends upon it's very important to see the contralateral refractive error in a unilateral cataract. So you might have a child who is myopic in the other eye, and then obviously your biometry would change, the target refraction would change what you, because you might have a younger child who has a high myopia in the other eye, and wants a cataract surgery. So in those cases, you won't be targeting a hyperopia in that case. You obviously would be targeting maybe metropia, considering the age and the myopic shift the child is going to have over a period of time. So those considerations are very important when planning, when calculating the IOL power in such a scenario.
Dr. Savleen, in unilateral cataract versus bilateral cataract, does it differ your IL power calculation or it is same?
So for a bilateral cataract, we can choose a moderate to even high hyperopia. If we do not have an keratometry reading, we can choose on the basis of exit length and dance, and we might implant in power, and we get a moderate or even high hyperopia. Bilateral, it can be corrected with spectacles. But if you have a unilateral cataract, that you do not want a very high hyperopia, because you'll get an immediate postoperative hyperopia, which itself is an embryogenic factor, and unilateral cataracts are more prone to amblyopia, and they have that component of deprivation amblyopia which does not get corrected even after you put an intraocular lens. So in a unilateral cataract, I would target a lesser hyperopia but still hyperopic aim.
So you mean to say that in a unilateral cataract you try to keep less hyperopia
As compared to a
because
bilateral,
otherwise it will be a gap will be
the
in bilateral
anisoconia
cases
between
it
two,
does not matter because if you are keeping say +4 diopter, that will be in each eye, so chances of amblyopia will be much less.
much.
But if there is a lot of difference because other eye is normal in the unilateral cataract, so you try to keep that difference very minimal.
We have to reduce the anisoconia, so the difference between the two eye powers should be less.
And I have some comment. Some of these children with the cataract have nystagmus. So in those cases, measuring the biometric parameters in the OPD become difficult. Even with IOL master, it might take a keratometric reading which is not right in the center. So in those cases, a handheld keratometer is very valuable because you're actually seeing where you are measuring with a handheld keratometer. Even the axial length could be a little off center in these children with nystagmus. So probably repeat them under general anesthesia in such cases. So because we have patients with nystagmus who have a poor prognosis when along with a cataract. So in these children, a double biometry, you can say, one in the IOL master if the child is cooperative and the other under general anesthesia should be done. Yeah, they're different available. Even NIDEC one is available, and what we are using is the Brighton. What we are using, that's a little expensive. Probably in the production in India has stopped. So NIDEC smaller one. Probably that's the only one which is available. Okay, because we are using the version which we got maybe 5 or 6 years back. And it does cost about 6 to 7 lakhs, that one. But the Indian versions are also available, which are cheaper. And one must have that option when you're dealing with such cases because keratometries sometimes just go haywire. Yeah, so as rightly said in the presentation, probably after 4 years, when we have to plan for an IOL, we would be making the child, we would plan for an emetropic power after 4 years in a bilateral cataract.